Maybe. So welcome back, everyone. So today we have Dr. Liebe, who's going to tell us a bit about himself and his academic journey, and also presenting his paper on subanesthetic ketamine suppressing the Locus Coeruleus and mediated alertness effect with high field MRI. As usual, any question are very welcome via chat. Thomas, over to you.
Thank you very much for this warm welcome and for this invitation to this talk. And my name is Thomas Liebe, and I'm in the residency for radiology. And since my doctoral thesis, I'm working in the field of ketamine and high field MRI. And I want to present you now something that is very, very interesting. Also, it was very interesting for me to follow this path, also to look at ketamine effects that maybe are aligned with noradrenaline. And now I will present you our newest paper about that and a bit about the path from the research that led me there. So our actual paper is called Subanesthetic Ketamine Suppresses Locus Coeruleus Mediated Alertness Effects, a 7 Tesla MRI study. And firstly, I want to give you a brief repetition of the how ketamine is aligned with noradrenaline in the body. I will talk a little bit about previous studies we performed about ketamine noradrenaline before this study. I will talk shortly about the study design of the actual study, present you the results, and then discuss the results shortly. And of course, we can then discuss everything together. And I'm looking forward for your questions. A short background to the noradrenaline system. I just want to mention that again, because sometimes if we now hear about ketamine, we always think about the NMDA receptors. And when I started to do research about ketamine, we also were thinking about the cardiovascular side effects of ketamine. So we know from the emergency medicine, especially that in higher doses of ketamine, we have a strong sympathomimetic effect. So we have an increase in blood pressure and heart rate. And this is due to an inhibition of the norepinephrine transporter, especially peripheral in the body. So you can see that here, that if ketamine inhibits the norepinephrine transporter, we have an increase of noradrenaline in the synaptic cleft, which leads then to an increase of blood pressure and heart rate. And we were interested if this also would have an effect, or if we could predict with this knowledge something more about the side effects of ketamine, and if we could refer that also to something that happens in the brain functionally. And if you look into the brain and are interested in the noradrenaline system, we should look at the locus coeruleus. So this is a brainstem nucleus, a small nucleus, bilateral in the brainstem, and it has really extensive connections to the whole brain. As you see here, we recently did a tractography study where we visualized the nerve fibers of the locus coeruleus, and in the end of the nerve fibers of the small nucleus in the whole brain, in nearly all brain area, we have an influence of the adrenaline to, for example, if we want to remember something and we have an adrenaline boost, we can remember things better. If we have any sensor information that goes in the body, especially through the thalamus, and it will be enhanced by noradrenaline. So we have a big influence of noradrenaline on our whole brain, and this all is controlled by the small nucleus in the brainstem, the locus coeruleus. And there's a lot of research now because we think that the locus coeruleus is also very important in dementia, of course in depression, and for example in PTSD. So this was the main reason why we looked also especially at this nucleus in the brainstem, locus coeruleus, because we were also interested in the side effects related to noradrenaline, and for the central effects, we wanted to look at the locus coeruleus in the brain. But in one of our studies, so the first study which I joined was ketamine, that was a parallel design study where we investigated about 80 participants, healthy participants, and they received over 40 minutes with the intravenous infusion in the same doses as in the antidepressive therapy, received subanesthetic ketamine. And there we were looking at the cardiovascular side effects of the subanesthetic ketamine. And there we also saw a bit what we would have expected from the higher doses also, that even already after 15 minutes in the resting lying position, we had a significant increase of the blood pressure. Here in red, you see the ketamine group, and here in the small dots in here with the box plots, you see the placebo group. So already after 15 minutes, we had a significant increase in the systolic blood pressure. The same after 20 minutes we saw in the heart rate. So even in the subanesthetic doses, we could see the increase in blood pressure and heart rate. And interestingly, we could also a bit more near refer this also to the norepinephrine transporter, because we compared dysfunctional. So in our population, we have 50% from a norepinephrine transporter carrier that works very good, and 50% that works a little bit less good, that the expression from the net is a bit reduced. And we saw after ketamine administration that in the group with the not so functional norepinephrine transporter, the blood pressure increased much faster. So here you see the points of the maximal systolic blood pressure after ketamine subanesthetic, here the administration time. And this was a lot earlier in this dysfunctional group than in the functional group. So we could a little bit relate also the side effects to this norepinephrine transport. And we also found gender effects. So in women, we found here is the diastolic blood pressure. We found that the extent of diastolic blood pressure, the increase was higher and faster achieved in the women than in the men in the subanesthetic doses also. And we also referred this from our discussion to differences in the sympathetic nervous system. Now we were looking in this older study also in the central effects inside the brain in the functional MRI. And what you see here is the functional connectivity of the locus coeruleus to the whole brain. So in the resting state, so in the resting participants in the MRI we were measuring, we were extracting the bold signal directly from the brainstem, from the locus coeruleus, and correlated this to all the activity in the whole brain. And what we found is that in the resting situation, the locus coeruleus is heavily connected to the anterior cingulate cortex, so to the frontal controlling brain, and also to the thalamus, and for example, also to the hippocampus. So we could visualize a resting network, activity network in the resting situation that is also related to noradrenaline in the brain. And then we were looking in the study. There, this was this parallel design study with ketamine. 1 hour after infusion, we're looking into the activity changes or connectivity changes in the brain. And what we found in the study, on the left side, you see the resting connectivity of the locus coeruleus. On the right side, you see the change of the connectivity between groups in a mixed design, with the time points before infusion, after infusion in the placebo and the ketamine group, contrasting these conditions. And there we saw that the locus coeruleus significantly disconnects from the thalamus. And this is a whole brain analysis that was very, very significant. So we were not specifically looking in the thalamus. We looked at the whole brain, what happens with the connectivity of the locus coeruleus, and it was heavily disconnected from the thalamus. The same you can see here. We had the ketamine group and the placebo group in a parallel design. And here in the baseline, here is the baseline, here is the after 1 hour. So after the infusion, we see this connectivity decrease of the locus coeruleus to the thalamus. Interestingly, I told you before, in the side effects in the same study, we had differences regarding the norepinephrine transporter genotype. We found that this connection between locus coeruleus and thalamus was especially pronounced in the group with the functional norepinephrine transporter. So the dysfunctional group did not really show a decrease. And this was also interesting for us that we could at some point relate it also more directly to the norepinephrine transporter, what we also saw in the activity change in the brain. Now we come to the actual paper and the actual study, and based on the results we had in this previous study, we were thinking about what could that mean, that ketamine disconnects the locus coeruleus from the thalamus. And there are studies from Peterson and Posner and from Aston Jones. They analyze a lot the connectivity from the locus coeruleus to the thalamus, especially from animal studies. And based on their research, we thought ketamine should change something with the alertness system, because especially connectivity from locus coeruleus to the thalamus is relevant for alertness. And shortly, I show how the design of the study is, or for the design from the study was. We had 35 healthy male participants with a mean age of 25 years, so a young study population. And this was a placebo-controlled, randomized, double-blind crossover design study, and with 2 treatment arms, as you see here. So everybody received ketamine and placebo. And what you see here is that we have a baseline condition with MRI, where we looked at the connectivity in the brain at the baseline. The participants stayed in the scanner, and then inside the scanner, they received ketamine with an infusion. And afterwards, the participants have to fill out questionnaires, and also did then an alertness task, which I show you in the next slide. Then there was a 24-hour after infusion MRI scan, a 3 weeks washout, and then we repeated the same procedure with ketamine or placebo. Shortly to the task, we wanted to know something about alertness, if ketamine would influence alertness based on these results we had before with the locus coeruleus thalamus disconnection. And we choose to apply the attention network test. Basically, this is a flanker task. Maybe some of you are familiar with this task. In this task, there are 5 arrows, and you have always to react with a mouse with a left or right button press if the middle arrow goes to left or to right, what is shown in the picture. And sometimes there are flankers. That means there are arrows on the side that distract you. Sometimes they are incongruent, so they go to the other side. And when flankers are incongruent, then it's difficult to react fast, and your reaction time is slower. And this is called the conflict effect. And this is heavily mediated by the frontal brain. And something else is implemented in this task, the cues. So before these flankers occur, you have cues that warn you that in the next milliseconds there will be the flankers, and they increase your reaction time. And these cues either are at a random position that does not give information where this flanker will occur, or they will be on a location where later the flankers occur. If they give you a cue where the flanker will occur, this is the so-called orienting effect. So this will help you to orient your attention fastly to the flankers. And if they are randomly somewhere, they don't have this information about the location. And this is then the alertness effect. So if you don't get any information about the location where the flankers occur, just a warning signal. If you have a warning signal before the flankers, this warning signal will decrease your reaction time and will make you faster. And this was the main effect we were interested. If this increase of reaction time that you have on the task, if you are warned, suddenly the flankers will come. If this would be influenced by ketamine. And what we also did is that we, in this study, extracted the bold signal from the locus coeruleus, from the exact location of the locus coeruleus, from every individual participant. So normally what you do is you take all the data, the MRI data from the functional data, and you bring it together in one mean brain. But here we wanted really to be sure from the small brain nucleus that we get it from the right location, and we applied a special sequence to visualize the locus coeruleus. What you see here, then we segmented the locus coeruleus manually and extracted for every participant a signal from the exact location, just to be 100% sure. And what we found here and what we could replicate is that the locus coeruleus heavily disconnects from the thalamus. So what you see here is the mixed design 2x2 ANOVA. So again, we have a condition before application of ketamine at baseline, and then the application of ketamine or placebo, and we contrasted this. And this is the contrast change. And then if you look in the post-hoc tests, only contrasting the baseline condition to the application of ketamine, we see this really, really whole brain, highly significant decrease of the locus coeruleus connectivity to the thalamus, to other brainstem regions, and to the cerebellum. So we really could replicate the former results of the old study in this new study. And then, of course, we were interested what happened with the alertness that I showed you before. Indeed, we found that in the behavioral result, the alertness was reduced. So here you have in the placebo condition, the alertness results, so the increase of reaction time to the flankers. And this effect of increase of reaction time was reduced in the ketamine application situation. And what was the most interesting point, we could relate this alertness in the behavioral results also to the functional MRI, because we found a correlation between the locus coeruleus connectivity to the thalamus that was correlated to the alertness. So, and this was also a whole brain result. So we didn't specifically look into the thalamus. So we looked at the whole brain and found that the functional connectivity of the locus coeruleus to the whole brain correlates to the thalamus. What we also were looking at is if the connectivity change of the locus coeruleus to the thalamus, if this would generally influence the activity of the thalamus. The thalamus is such an important key area in the brain. And we found that if the locus coeruleus disconnects from the thalamus, the decrease of the activity of the thalamus that we found due to ketamine correlates to that. That means the higher we had a disconnection from locus coeruleus to the thalamus, the higher the activity of the thalamus was also decreased with the ketamine administration. Now we come shortly to the discussion. That was our overall model I tried to build for my doctoral thesis, that we have in the peripheral body here. So you see the brainstem, the heart, the vessels, that we have an increase of blood pressure due to ketamine, due to increase of noradrenergic. At the same time, we have a change in the activity from the locus coeruleus and a disconnection from the locus coeruleus to the thalamus. And if you look at the whole model from the brain, I'm really interested to follow this path and understand better what this disconnection from the locus coeruleus to the thalamus means for the whole picture we have about ketamine. I mean, we know a lot about the default mode network, that this is very important, that the changes without the default mode network, that they correlate also to the antidepressive effects of ketamine. And one of my ideas is that it could be that that generally in depression we are very focused of negative thoughts, and I believe that and there are also patients that have hyperarousal in depression, and I believe that this disconnection from LC to the thalamus could help to break through a maladaptive hyperarousal and maladaptive focus on specific thoughts, and also help to find a new balance between attention networks and the default mode network. So to summarize everything shortly, what we found out is that ketamine in the subanesthetic doses elevates blood pressure and heart rate, so has sympathetic effects dependent on the individual noradrenaline system, dependent on the norepinephrine transporter genotype, and also dependent on gender. We found out that the central noradrenaline network is influenced by ketamine in the brain with a reset of sensory signal processing pathways, so a disruption of the locus coeruleus to the thalamus, which is related to a thalamic activity decrease. We found that the central effects of ketamine on this locus coeruleus thalamic network are related also to a behavioral alertness reduction with ketamine. And I think it's interesting to make more research about if ketamine could counteract hypervigilance and attentional bias by disrupting this locus coeruleus thalamic connectivity, and in an acute situation, lowering alertness, and with that support a reconfiguration of brain networks together with the default mode network. Yeah, so thank you for your attention, and I'm looking forward for your questions. And here I want to thank all the team that made this really, really interesting study possible. And also after the talk, you can always write me here in this email address, and I can also answer all the questions that we maybe cannot catch up now in this talk.
Thank you very much, Thomas. Interesting work, interesting talk. So I see Rupert is raising his hand, and then we have a question in the chat. Rupert, do you want to maybe kick off?
Yes.
Or actually, maybe it seems like he's a bit busy. Maybe, Tiago, do you want to ask your question directly in the meantime? I see you put a question in the chat.
Hello, amazing work. Thank you.
Hello, thank you.
I was wondering if we know by seminal works with ketamine that ketamine may turn thalamus down, and you were showing us, I got a little bit confused if it shuts down thalamus, it shuts down locus coeruleus, or the connection between them, or everything down.
Basically, what I know from the data is that the connectivity shuts it down from locus coeruleus to the thalamus. And this shutdown from the connectivity from locus coeruleus to the thalamus relates to the general shutdown from the thalamus. To look at the actual activity mode from the locus coeruleus is very difficult. There are even this is very difficult. So it's a bit easier to look at the connectivity. What is there a change? And it's not super straightforward to say we see now a disconnection from locus coeruleus to the thalamus, and we can say the locus coeruleus now goes up in activity or down, because the electrophysiology of the locus coeruleus is quite complex. And I believe if we have a very high activity of the locus coeruleus, then we should not have such a good connectivity from the LC to the thalamus. And when the activity is very low, also not. And when it be in a good middle, the connectivity should be good. So the relationship between the connectivity and the activity from the locus coeruleus is not one-to-one.
I'm asking this because on basic work on ketamine, the dissociation phenomena is a thing that everybody was searching back in the 60s.
Mm-hmm.
Are we mimicking schizophrenia? Is this schizophrenia, or it's not? It's this hallucination, or it's not? Nowadays, people are saying that maybe the dissociation and things that people see when we use ketamine is the same as psilocybin or other psychedelics. Is ketamine a psychedelic? And there is this whole discussion. But on the basic work, they understand that when the thalamus is a central hub for sensory input. So everything, it's the gate for pain, it's the gate for every sensory input. So if you when you shut down the gate, so no one can enter anymore in the brain, your brain doesn't stay open in the void. So it generates its own things to think, to feel. That's what is the dissociation images that people see. There's nothing to do with serotonin agonism from psilocybin or any other psychedelics. So that's what I'm wondering. Are we shutting down the gate, thalamus, or locus coeruleus and then locus coeruleus there? And if these seminal works are corroborated, are true, or we are discovering something else on this phenomenon?
Mm-hmm. Okay, I think there is something in this question maybe that I can answer, or that I can try to answer, is how the shutdown of the thalamus could be related to the LC regarding the results we found here. And I can imagine that it's some way directly related. I mean, I found a correlation. This can always be also something about a third or fourth part, but it may be if you go to the neuroanatomy from the locus coeruleus, as I showed you in one of the first slides, if you go to the fibers from the locus coeruleus, most of them go to the thalamus, and the influence of noradrenaline inside the thalamus with the locus coeruleus is quite important. And we know also from animal studies, if we destroy the locus coeruleus, of course, all the vigilance is away. So from these results, in a way of a discussion, I could think that the locus coeruleus would have an influence on the thalamus in this way. Anyway, I mean, with different drugs that maybe all have also an influence on the thalamus, like also clonidine, we see a lot of differences in the effects in the end. So what I believe is that maybe this is a puzzle piece of the effects of ketamine. I don't know yet how important it is, but I think it's a puzzle piece, and it makes a lot of sense also with the important location of the thalamus in the brain function. But maybe it's not the whole picture alone. So I want to mention also one study regarding the thalamus. This is I really like the study. It's from Anna Höflich from Vienna, and she was looking at the thalamic connectivity changes due to ketamine. And they also found that is a huge change in the connectivity from the thalamus. And yeah, this also supports, I think, the idea that the thalamus is an important hub also in the ketamine effects.
Do you know if there is any connection with thalamus or locus coeruleus with lateral habenula?
I would say that habenula is also connected with the locus coeruleus. I now cannot say how or if it's already known how big are the influence. I mean, there are also a lot of incoming fibers to the locus coeruleus that regulate also the locus coeruleus. For example, the anterior cingulate cortex, interestingly, has very long fibers that go to the locus coeruleus and control the locus coeruleus. So if you're interested in that, I would also think in both directions that a lot of brain regions, even top-down regions or other regions in the area of the LC can have a significant impact on the activity of the locus coeruleus. And with that, maybe to the thalamus. So.
Hi, can I ask a question?
Yeah, sure. I'm happy.
Yeah, hi. Yeah, sorry about the interruption. My wife came in and she just told me she got a 5 million quid grant, so she's very happy.
Wow, congratulations.
Yeah, so we're all very pleased about that. Yeah, so my question is I didn't quite understand if ketamine blocks the noradrenaline transporter, and so increases the amount of noradrenaline. How does it? Why does it reduce the connectivity between the locus coeruleus and the thalamus? I mean, you think it seems to me that you're saying there should be more locus coeruleus drive. So is that a stupid question? Have I misunderstood?
No, this is just a very complex question. Of course, I thought about a lot about that, and there's a lot to learn about that if we raise this question, because the interesting thing is we know a lot about the locus coeruleus. It's a small brain nucleus. There were a lot of research about that with electrodes in monkeys from Aston Jones, and they looked at the activity modes and the electrophysiology. And what I can show here, I hope you see it, although it's a bit small, is that there's a tonic activity of the locus coeruleus. And if we have a very high tonic activity, something like a hyperarousal, we cannot really concentrate on tasks. We are more prone to looking around and concentrate on new information and do something else. If the activity is like in the middle, like a good middle of the activity, also from the arousal, we can very good engage in task. And if it's too low, I mean, the vigilance drops and we cannot really engage in tasks. And if we now block the norepinephrine transporter, generally what we know about the LC, it would lead to an increase of noradrenaline around the LC. And interestingly, we have a lot of alpha-2 receptors in the LC, so this would decrease the LC activity. So, but I have to say, we cannot relate so far really that we say, okay, ketamine has a very low affinity of the norepinephrine transporter, and we cannot so far say it's really ketamine directly on the net that changes the activity of the LC. For example, there are also a lot of NMDA receptors in the LC, so this could be also a point where ketamine influences the locus coeruleus and changes the connectivity that we saw before, and this would also more lead to an activity decrease. So I can so far not say for sure. What we see is that in the behavior, the alertness is reduced. In general, this could be due a little bit shifts the tonic activity to the higher or to the lower state.
Yeah, sort of Yerkes-Dobson curve, isn't it? So, yeah, can I just ask a methodological question? Just to sort of help us contextualize it with the sort of clinical experience. I saw that you were using a dose of 0.1 milligram per kilogram bolus, and then a maintenance dose of 0.22 milligrams per kilogram. And I wasn't sure whether that was administered over the whole of the 40 minutes. So it's a sort of, it's less than the normal dose that we'd be using therapeutically. Is that right? It would be about 0.33 milligrams per kilogram overall over the 40 minutes.
Yes, so generally the idea from this scheme was to make it work during the ketamine infusion so that you have a bolus and fastly you have a good level, and then in time can perform the MRI measurements within the scanner.
So it's consistent.
And of course, this is a little bit different from what you give in the clinics. But what is nice, I mean, I showed you the other study where we also showed the same effect. And this was like the exactly same scheme that was no longer used in the psychiatric therapy with the 40 minutes and the 0.5 milligram per kilogram. And even after 60 minutes after infusion, that was the old study, we found this disconnection from LC to the thalamus. And here we found it during infusion. So I think this shows that it's not related exactly. So I think it's related to the subanesthetic doses of ketamine, but it's not like an exact dose we have to achieve to see this effect.
Thank you.
We have a question on the chat. Julia, you're more than welcome to ask it yourself, but if you're not comfortable, maybe Thomas can read it out loud.
So in the chat.
Please read. Okay. Yeah, I can read this to you otherwise, Thomas.
Oh, that's nice. Thank you.
Julia is asking, do you know of anyone looking at the effect of ketamine on the anterior mid-cingulate cortex? I'm curious because of the clinical effect of people having more ability to engage in difficult things.
Could you rephrase the last part of it? That they could engage in?
I'll hop on.
Oh,
okay. So basically, after they have the ketamine treatments, especially with the right guidance, they're able to motivate better. They're able to handle things that they previously were not able to handle, whether it's difficult conversation or exercise regimens. So there's been some conversations like on Huberman where he talks about this part of the brain being particularly important when you look at people who, the 80-year-olds that's very active and motivated, this part of the brain is bigger. And this changes day to day. So like if you stop doing things that challenge you, this part actually shows less activity. So is there any like if anybody's looking at this, or if you noticed anything, that might suggest there's a role here?
Yes, I mean, how long is the time between the effects that you speak now about? How long is the time distance from application to what you saw?
So generally, I'll see that the first maybe 24 hours, they're still, maybe some people are a little bit more tired, but then after 24 hours, they seem to have this motivation and forward momentum.
Mm-hmm. Okay, so this is a super interesting question, and I hope at some point we have a really holistic view about the ketamine effects. And what I can say now about that is that I believe this is a bit what I showed in one of the last slides. To refer it also now to my talk. I mean a bit what you tell me, it sounds for me a bit like behavioral flexibility. And I mean, if you look at patients with depression, I think they are highly focused on their negative thoughts. They have a lot of rumination, and they have hyperconnectivity in what we know from a lot of studies, or what we believe is that they have a hyperconnectivity in the default mode network. So if you think about patients that constantly ruminate, that have negative thoughts, they cannot engage so well in new tasks and cannot be so flexible. So what I believe is that the connectivity change from the locus ceruleus to the thalamus, what we see here, and the decrease of the thalamus, for a short time, it opens a gate out of this rumination at some point. And this could also support a reconfiguration of brain networks, also involving the default mode network that is constantly busy with these ruminations. And then a little bit later, because here there are very acute effects during infusion, together with BDNF, what can help to rewire the brain, can lead to more behavioral flexibility. And because you talk about the anterior cingulate cortex, this is heavily involved as a top-down control region. In the one hand side, also to the locus coeruleus, because it controls the locus coeruleus, and it is also involved with the medial prefrontal cortex in the default mode network. So I would think that maybe this could be a connecting region, in the sense that a reconfiguration of this region could lead to enhanced behavioral flexibility.
Thank you so much.
So, Thomas, if I may ask a question, like, so your study was on healthy volunteers, right? So how would you see this translate in a clinical population in the most meaningful way? I think you're hinting about like targeting like rumination, for example, in the context of depression. But I was also wondering if you can comment a bit of what the translation would be, for example, in the case of PTSD.
Yeah, you mentioned that before the talk started, that it's very, very interesting for a lot of people to translate ketamine also maybe to other diseases. Firstly, I would suggest to be a bit careful in the beginning, because actually ketamine will change alertness. It will change something in the locus coeruleus system in the acute effect. So I think it's a bit hard to predict in the very, very early application what it will do with the PTSD patients. It could be even that it increases the locus coeruleus activity, and this could be, so it should be applied carefully, I would say. And what also is something that I believe in application of ketamine, I think regarding the effects we see here on the locus coeruleus, it could be also, the effects could be also dependent on the actual activity of the locus coeruleus, the activity of the sympathetic nervous system when we apply it. So this is a point I think that should be treated with some care, that we influence that heavily. So you see that on the blood pressure increase. And I think in PTSD patients, I would, if it should be tried, I would try it carefully. In depression, how we say for the rumination, we have a lot of experience. I mean, we have also hypervigilant depression patients, and we see a lot of beneficial effects. So I just want to say that it should maybe used with some care.
As part of this work, sorry if I have another question. As part of this work, did you also take a look of any correlation with some scales, right? So I'm more aware that these are healthy volunteers, but for example, where there's like any correlation with dissociation, I know the dosage was lower, but did you observe any dissociation? Was there any correlation with the basically experience that they had during the time of the infusion, or any other maybe cognitive measure that you collected since you were studying alertness?
So basically, in this study, we are still a bit on the beginning to understand the influence of the locus coeruleus to the thalamus. So a lot of work we put in is also to the methodological challenges. So I think this is also a very big next step to relate the connectivity changes from the locus coeruleus to thalamus also to the broad network changes. But I would predict that solely looking at the connectivity change from the locus coeruleus to the thalamus maybe will not bring all the dissociation effects. And this is a bit related to something we were talking about before. If we only look at the thalamus changes, there are a lot of drugs that do that. And that's not enough to understand the whole picture. So I think we have to find more a whole picture, like a influence of the locus coeruleus thalamus disconnection with other networks in the brain, and then we would find a direct relation to the side effects of ketamine.
There may be some question in the chat if you want to take a look. Somebody was asking about some properties of ketamine in reducing anxiety, maybe like via GABA receptors. Do you have any thought about that?
Could you repeat that question? Sorry.
So that Tiago was commenting, interesting that even upregulating norepinephrine still improves anxiety symptoms. And John commented, perhaps other properties of ketamine in reducing anxiety, like via GABA.
I mean, from the locus coeruleus network, I cannot relate it so much now to the GABA system, but in generally, I think the important thing with ketamine is the reconfiguration of networks in the broad scale and also the BDNF change. So I think it makes sense to relate that also to changes like anxiety more than we think now. Okay, so for example, this effect we have from the locus coeruleus to the thalamus, this is a very acute effect, and like Julia now said, we have very late effects also that really relate to the behavior. Then I believe more what we see here is a very, very acute effect that influences the whole interplay of networks, and then we have later effects that maybe mediate anxiety. So I would always frame it in this picture.
You, for example, disconnect what is like the maybe ketamine rapid effect versus what is maybe the sustained.
Exactly. We had another talk before from Lena Danieli, who also worked on the study. It's 43. You can rewatch. And she was talking a lot about the default mode network changes in the acute phase and in in the late phase and how they relate to each other. This is very interesting, and I think this is really a key point to have in mind, that we have acute changes in the application that also translate to other diseases that may be reacting differently on ketamine, and then we have late changes. For me, it's like in acute effects, we open a gate, and then we have late changes that is a lot of rewiring of the brain.
Rupert just popped some question in the chat.
Yeah, can you just remind us, is the this result where you're relating the alertness, the reduction in that, to the disconnection of the locus coeruleus and the thalamus, if I've understood that correctly, is that based on the scan during the infusion, or is that related to the 24-hour scan?
This is the very, very acute effect of during infusion.
Right. So this is how much they're actually obtunded by the infusion.
Exactly.
Yeah. Okay. Yeah, it's sort of relevant, isn't it? Because I mean, if you think that the dissociation that people get, which is related to the change in alertness at some level, if you think that that's relevant to the change in depression, then this is obviously relevant to that. Yeah, sorry, thank you. And then the other question I had is this the same group that was studied in the other study that you just talked in, Lena's study?
Yes, it's exactly the same.
Exactly
same
same
study.
group. Yeah, same experiment.
Yeah.
Okay.
Any reason why you enrolled males? I'm sorry if you mentioned that and didn't catch that. I think your sample are all males, right? Do you have any specific reason for that? And I think in your paper you go over also about this, but how do you feel in terms of generalizability of these findings?
I think the basic reason, I don't want to say something wrong because I did not alone design the study, but I think this was for a specific question, because one of the things was to make spectroscopy in the brain, and there was a specific question where, dependent on the sample size, I think the decision was made like that. But in terms of my results, I can say in the previous study we had a mixed sample. And yeah, we've also found a disconnection, and also in the previous study, so in the first study we did, I present here, I was also looking at gender effects, and so I specifically looked at both groups from men and women, and I found this disconnection from the locus coeruleus to the thalamus in both groups, male and female, and also it was not really a difference. So it could have been that in women it's more, in men it's more disconnection, but there was not any gender effect. It could have been because in the side effects of the blood pressure and the diastolic, especially, we had a difference from the gender, but in the disconnection there was no difference.
Thank you. I'm also mindful of time, so does anybody has any question for Thomas?
Yeah, I was going to ask, was there a correlation between the increase in the blood pressure and the extent of the disconnection, or between the increase in blood pressure and the reduction in alertness?
There I did not found direct correlations, and I think this is to the nature that the whole picture is a bit more complex, and methodological, I would not say problems, but things that make it more difficult to find a direct correlation. Because, I mean, if you look back on this big model, here, the LC is here, okay, it has a considerable influence on the blood pressure, especially with the locus coeruleus. It's like if we have a trigger peripheral in the body that increases the blood pressure. In this case, it would be a block of the norepinephrine transporter. We have an increase everywhere in the peripheral body from adrenaline, and the blood pressure goes up. The LC tries to counter-regulate it. And I think it's very hard to find really a direct correlation in this, because we have also, it's not the only counter-regulation effect. I mean, I in the first study, I was extensively looking also for that, but I think a direct correlation you will not find there. Actually, there is a study that was a little bit earlier, also performed in Magdeburg, where they were looking at the heart rate variability with ketamine. And there they found a region in the frontal brain, actually, I think from the anterior cingulate cortex, that correlated to the heart rate variability change. So maybe we even have to look at a higher order area in the brain that is then connected to the locus coeruleus, for example, to find correlations directly to the blood pressure. But really directly to a disconnection from LC to the thalamus, what is very specific in the alertness system, maybe it's too straightforward to expect a direct correlation between those measures.
Professor Mann, I see you have your hands up, and thank you for joining us.
Yeah, thanks. Sorry, I joined a bit late, had a meeting. But yeah, fascinating study. I really like this. Apropos the last question, there is a, I'm just looking at your picture, the RVL section in the brainstem where when you enhance noradrenergic input into that area, you may actually lower blood pressure instead of raise it. So that might be an intracerebral mechanism for which may disconnect some locus coeruleus effects from blood pressure effects. You know, it's not like everything goes up. But what I put in the chat was a question really, because when you're looking at acute effects, I really like the idea of separating these acute effects from the delayed effects. But when we look at acute effects in the scanner, while we're giving the ketamine and they're in the scanner, we see GABA enhancement. So if you see GABA enhancement, that might be like an antidepressant, anti-anxiety effect, which could be going along at the same time. And also those inputs could be impacting the locus coeruleus at the same time. So it's quite a complex set of orchestrated effects that are going on, even though everybody thinks locus coeruleus, activation, blah, blah, blah. But, you know, ketamine has very acute effects on the serotonin system, the noradrenergic system, the GABAergic system, the glutamatergic system, and they're all talking to each other at the same time in that acute moment.
Yes, I totally agree. And this is also because then I get the impression, if I also make a talk about that, is that like our brain is, we always want to have a one-shot silver bullet solution for how ketamine works. But actually, how I feel, I'm very careful with that. And I mean, I see this effect. I could replicate this now in 2 studies and to a behavioral effect of ketamine. And I think it's related to that, but I think it's a little part of the whole picture. And I think the default mode network, the rumination, this all comes together, and it's a very important part. Of course, the GABA is super important, the serotonin, the NMDA receptor, and this is then the specific mix that makes the drug. And I think it's a reasonable part that we can show here. But it's not about we should now think ketamine is a noradrenergic drug or something. I mean, we have the side effects. It has some effect in the brain. It has something that adds something to this mix that makes ketamine so successful. But sure, it's not even a very. It's a considerable part, but it's not the whole picture, of course.
Anyone has any further question?
I've got another one. Sorry, hope you don't mind. So Nuri Farber from Washington, he did a study where he gave people 56-hour infusion of ketamine. And he gave them also a low dose of clonidine regularly during this period. And he said that the reason for doing that was to reduce the dissociation. So he obviously had he had a theory about why that might happen. I can't remember what it was, but I just wonder whether this fits with Tiago's. I mean, whether this fits with your work and whether it fits with Tiago's theory about shutting the gate or the thalamus and then the brain developing its own dreamlike state in response to the lack of stimulus.
Yes. So, I mean, if you now go back to my model, what clonidine actually does, it's an alpha-2 agonist. I'm not saying something crazy now, but I would expect what clonidine does from the locus coeruleus. Actually, there is a functional MRI study that investigated the influence on the locus coeruleus functional connectivity, even, I think, with clonidine. Clonidine will lower the SE activity, that's for sure. And I mean, it's really interesting that if you combine it with ketamine, there is a change, and this at some point supports also the finding here. That's really interesting. I mean, but anyway, clonidine also has other effects in the brain. But I mean, if you now relate it only to what I presented now, I would say clonidine actually decreases the SE activity, and maybe in this way could have also a counteracting effect on ketamine, on the specific part of the effect.
So it would allow people to maintain alertness as well, maybe.
Clonidine is actually a bit sedating.
Exactly. Well, that's
it's an autoreceptor agonist. It's turning down firing rate, so it's it reduces alertness.
Yeah.
Yes.
So it doesn't fit. Okay.
No.
All right.
I use sometimes clonidine to lower blood pressure during infusions, and I don't think it changes the association.
This doesn't it? Okay.
I don't think so, but I don't use it very often, but I just think that it doesn't change the association. Just
John, do you ever use it? Do you ever use it for anxiety?
Never for anxiety. I never use it for anxiety. Oral, yes, but not IV during infusions. Sometimes I use the oral for anxiety. It doesn't do something. It's the same thing as nothing.
John, do you have a comment on that?
People have used it to try and deal with rebound anxiety related to drug abuse, because it turns down the locus coeruleus firing rate and reduces the hypervigilance and overstimulation that they're experiencing. So this is a few years ago, but it has been employed in that kind of way.
Thank you.
Well, I think we're coming to an end of our session today. Thank you so much, Thomas, for presenting your work, and all of you for all your questions and the discussion. So we see you again, yes, on the 10th of December, before our holiday break. Thank you very much. Have a nice rest of your day. Bye-bye.